A very good afternoon, everyone, and welcome all the people across the world. We welcome you for the first episode of Vertebral Views, the Spine Show. Today, we have Dr. Michael Kelly, who's talking today on the topic, the spine sagittal alignment and what spine surgeons should know about the deformity correction. Dr. Michael Kelly is Director of Scoliosis and Spine Deformities in the Division of Orthopedics and Scoliosis at Rady Children's Hospital, San Diego, California. He continues to perform research across the ages as a member of the International Spine Study Group and the Harm Study Group for Pediatric Population. He also is part of the AO Spine Deformity Knowledge Forum. He serves on the board of the directors of the Scoliosis Research Society. We are very much grateful and thankful to Dr. Kelly for sharing his knowledge from his really busy schedule. Over to you, Dr. Kelly.
Yeah. All right, thank you very much. This is a topic that has been near and dear to me over the past handful of years. Having worked with Keith Bridwell and Larry Lanke, I did their fellowship, and then I practiced in St. Louis at Washington University for a decade, learning all posterior all the time. And then Manish Gupta came in and showed me the light to the sagittal plane and really introduced me to a lot of other types of thinking. And it continues to evolve for me. So here are my disclosures. Goals, we're going to discuss sagittal plane development, and that has implications, I think, for how we think about this in terms of adolescent idiopathic scoliosis, which is something I wrestle with now, to understand sagittal balance and economy, and then to think about the proposed alignment schemes that are out there and their faults. I think that there are some that are very popular that are not based in reality or reasonable mathematical thinking, and we need to move away from them or prove them right. But I think as proposed now, they're with great fault and probably should not be considered truth. So in general, right, the sagittal plane, we develop in utero globally kyphotic, just like apes, and we develop in kyphosis, and you have primary sagittal plane curvatures, which are thoracic kyphosis and sacral kyphosis. And as you become mobile, the curvatures change, and they change in an effort to maintain and offer horizontal gaze. So first you get tummy time and you have cervical lordosis when you're trying to see up. Then you get lumbar lordosis as you start to crawl. And then when you stand erect, that is where they begin to mature. And the French Spine Study Group, Pesenti, and Jean-Charles Philippe have done very good work describing how the maturation of the sagittal plane goes through early adolescence. And it's, I think, reasonably fair to say that around 13, 14 years of age, once you're approaching skeletal maturity, though not necessarily completely skeletally mature, you have developed the acquired sagittal curvatures and the sagittal balance that you are going to grow up with. And that puts you into what Professor Dubussé called the cone of economy. The cone of economy is a very small sort of cone within which you can stand without expending much energy. And it is a balance of lower limb alignment, which in reality is extended hips and knees, right? Because if you think about, if you need to crouch to maintain horizontal gaze, that's a lot of work, and you're expending lots of amounts of energy and clearly out of the sagittal, out of the cone of economy. So it's lower limb alignment, extended hips and knees. It's a balance then of the pelvic incidence, which is a measure of the takeoff of the sacrum within your pelvis. Lumbar lordosis, which then drives your thoracic kyphosis, which then dictates your cervical. I have written here cervical lordosis, even though in reality, it's cervical alignment. And there are a number of patients that do not have cervical lordosis, nor had they ever had cervical lordosis because of the way that their spine matured. And a flat cervical spine is not necessarily abnormal. So flat cervical spine in the absence of loss of disc height or posterior musculature wasting is not necessarily abnormal. It may actually be normal for the patient. And you need to think about that. And I a number of years ago, actually sort of proposed that we should really be getting EOS films on everyone, right? Skull to sacrum, even though I like skull to ankles. One of the surgeons here at UCSD really balked and said he could do everything he needed to do off a lumbar film, which I think maybe it was true in 1985, but it's no longer true in 2023. We really want to see the whole thing so you can understand where they are in the cone of economy. It's important also, in both, like, there's two themes here for me now that I'm at Rady Children's that are a little bit different. It's one that the maturation of the sagittal plane in the setting of adolescent idiopathic scoliosis may be totally different, and how you achieve sagittal balance may be totally different. And aiming for normal and population averages is probably not the right answer. The second is neuromuscular scoliosis and other patients that only sit. If you fix them like they stand, they hate it, right? If you look carefully at the neuromuscular literature and harm study group CP literature, if you leave lordosis, they don't like it. And there's a very nice study from China at the last AO Global Spine Congress about what happens to the lumbar spine with sitting. And in general, people sit with 25 to 30 degrees of lordosis, irrespective of their pelvic incidence. So you don't want to follow the thoughts of cone of economy and Roussely when you're fixing patients that do not stand. This is all about standing and minimizing energy expenditure when you stand. And so what about the cone of economy? And I think this is where ideas get conflated and confused. Leaving the cone of economy is a frequent indication for surgery because for some patients it is disabling. However, life is a kyphosing process, and leaving the cone of economy is not necessarily what drives your disability, and it is certainly not what I would use as an indication for large surgery. So I think one of the overarching messages, I've given this talk in a bunch of different versions, and one of the messages that I have not done an effective job of getting by is that this doesn't mean everyone needs a T3 to the pelvis. That's not what I'm saying. What I'm trying to convey in this is the importance of understanding what's normal and what is not, and providing personalized prescriptions for segmental alignment rather than group averages. So, right, people do leave the cone of economy, and there's no debate that it can be debilitating, but it is not ubiquitously debilitating. And you can see here, these are two patients. One is a ankylosing spondylitis patient that has been sent to me with no complaints, right? And those are terrible looking x-rays. He's got a little bit of knee flexion. He has pelvic retroversion with a vertical sacrum, but his spine is fused and he has horizontal gaze and was not unhappy. The other patient is an iatrogenic deformity with a flat back with pseudarthrosis, very flexed hips and knees. You can tell by both the vertical sacrum and the angle that the femur takes off at there, and the head's not on the x-ray. I tell people, when your face isn't on the x-ray, we got a big problem. And so as we looked at these sagittal planes and tried to think about how can we sort of classify or organize our thoughts more than just coronal Cobb measurements, Frank Schwab and the SRS first proposed the SRS-Schwab classification. One of the keys to this was that they integrated and understood the importance of the pelvic incidence that had been proposed by the French, right? That the pelvic incidence is the sacral plateau, and it drives your lumbar alignment and thoracic alignment and global sagittal plane alignment. And this was an early venture for us into trying to classify and prescribe treatment or think about how people stand. And it gave us very simple categories and equations. That's what we like. I would say one thing to note here is that, so they have PI minus LL. And then you have non-pathologic as people where that PI minus LL is less than 10. And I would have everyone note that it's not the absolute value of PI minus LL is less than 10, which is what this has become distorted into. Right, and that's a 20-degree range, and that's not correct. Then they say moderate deformity is between a difference between 20 and 10 degrees, and marked deformity is greater than 20 degrees. And all of these were based off of preoperative values based upon ODI measures. So this was geared towards health-related quality of life. One of the problems is that this didn't really give us alignment targets other than some range of LL to fall within for the PI there. And the other thing is that SVA and PI LL mismatch are highly collinear, meaning that as one goes, so goes the other, and so does pelvic tilt. The other problem really too is that pelvic tilt varies with pelvic incidence. And there are patients for whom a pelvic tilt of 20 to 25 is normal and not moderate deformity. There are patients for whom a pelvic tilt of 18 degrees, for example, someone with a PI of 35 or 40, is actually quite high, and it would be classified as non-pathologic. And that really highlights the problems caused by the categorization of continuous variables. So if you look at this, right, SVA less than 4 and 4.1 are different categories. 4 and 4.1 are not different, but they fall into different categories. The 4.1 that then gets lumped with someone that's 9.5. And we really, in 2023, we begin to miss the trees in the forest. And as we move towards precision medicine, we need to identify the trees, know what kind of tree it is, and know how to fix the tree. We can't just look at the forest. And so if we're going to operate, then the goal is normal, right? We want it to be normal. I would encourage everyone to read this little editorial from Stephen Jay Gould, who was an evolutionary biologist who had cancer. And he wrote this, "The median isn't the message," after receiving his cancer diagnosis and saying, well, how much longer do I have to live? And they said, well, on average, people live 8 months or something like that. And as a very astute biostatistician, he said, well, I don't really care what the average is. I want to know what my number is. And that's where we need to go, right? We know that the pelvic incidence is directly linked to sagittal plane alignment. And that led to papers with this commonly cited LL within 10 degrees, right? Which is a 20-degree range, which is very inaccurate. And that gives you a huge range to be okay. Suppose you had someone with a PI of 40 and you have someone whose whose lumbar lordosis is 49 and someone who's 31. Those are totally different situations, but they're the same by that equation. And that's nonsense. And I think that aiming for lordosis is really a windmill, right? We're chasing down the wrong thing. I think one of the first people to really, I think clearly, some other people say like, I can't make heads or tails of this. Hopefully I'll help you make heads or tails of this, because I love the Rusali classification. And Rusali described the importance of sacral slope and standing alignment. And he used sacral slope. I write pelvic incidence because he used asymptomatic volunteers who were hopefully standing normally. And hopefully we're not operating on lots of normal people, right? We tend to operate on patients with degeneration and engaged compensatory mechanisms, which include first pelvic retroversion. And if you have pelvic retroversion, that's increasing pelvic tilt, which drives your sacral slope down. So you cannot classify people before surgery according to their sacral slope if they have compensatory mechanisms. And this is like people fail to grasp this, which is a shame. And there are publications, peer-reviewed publications in the literature where people go through their preoperative films and classify according to Rusali, and then it's all nonsense. They say, oh, well, they had like 30%, 40% Rusali ones. No, they did not. Rusali ones are very uncommon. And what they had was a bunch of people with high pelvic tilt, low sacral slope, and a very degenerated thoracic spine. So they had global thoracic kyphosis with a little low lumbar lordosis and pelvic retroversion. So you got to understand that this is according to normal standing alignment. And he initially described 4 distinct subtypes for standing alignment, was later refounded to 5, which I'll show you on the next slide. And it was based upon the sacral slope and the shape of the spine, the shape of the lordosis, and the shape of the kyphosis. And one of the really important takeaways also is that they recognized, and they call it functional lordosis, which that word doesn't really make sense to me there, but it's the idea that we have always said, okay, like the 12-1 disc or the upper end plate of L1 to the sacral end plate is lumbar lordosis, L1 to S1 lordosis. That's not necessarily true. If you have a very low pelvic incidence, your lordosis may be all low, and L1 to L3 may be slightly kyphotic. Conversely, if you have a PI of 85, you may have lordosis all the way up to T11. And so measuring L1 to S1 really is not where it is. It should be maximum measured lordosis and maximum measured kyphosis, but it's also the shape and the distribution, right? And the distribution is what leads to the shape. So the Russley classification, I'll go through how he does it and then how I think about it. So it's 5 types. And in general, right, low grade PI is pelvic incidence less than 55 or so. And as you go more left on this screen, right, you have type 1s. These are very low pelvic incidence, low pelvic tilt, and high sacral slope. And those patients will tend to have very low arc of lumbar lordosis and a global kyphosis that goes T3 to L2 or L3, and then a little turnaround there where the apex of the lordosis, which is difficult to describe also because that's a postural measure. That if you just think about what happens to your apex of lordosis as you rock back and forward, your apex changes. But it's low apex, the L5 vertebral body or the L4, L5 disc. And then a type, that's like a C, right? The shape is a C with a little squiggle at the bottom for all your lordosis. It's the type 2s, type 3s, and type 4s that have the more classic shape that we're thinking about with thoracic kyphosis balancing with a lumbar lordosis, right? A very subtle S shape that becomes accentuated as your pelvic incidence goes higher. So if you go from a type 2 to a type 3 to a type 4, the pelvic incidence goes higher, right? The lumbar lordosis magnitude gets larger, and the apex of the lordosis measured goes higher. So in the type 2, the apex is around the L4, L5 disc, and L3 is around the L4 or L4 vertebral body or L3, L4 disc. And then a type 4 can really be type, L3 vertebral body for the apex. And with each of those, because the lordosis is increasing, you get a subsequent increase in observed thoracic kyphosis. But all of this is just an effort to put C2 over extended hips and knees, which is what Professor LeHewick has called the odontoid hip axis. You'll see later we talk about the C2 pelvic angle and C2 tilt. You want, in general, irrespective of pelvic incidence, people stand with a really low C2 tilt. Russley also described, and if you look, you certainly see this in AIS practices, the type 3 anteverted. So it's someone with a low pelvic incidence, but has a type 3 shape, right? A more accentuated S than a type 2. And the way they deal with that is by anteverting their pelvis. And they send their hips back so their PT can be 0 to negative. That is not a shape that you want to end up with metal in their back. So type 3 anteverted is not one to try and recreate. You only want to make 1s, 2s, 3s, and 4s. So now we understand shape, understand distributions, and what's the goal? What are we trying to do, right? We want to improve symptoms, clearly. That's why we're doing the surgery 95% of the time. The other things to think about is that we want a durable result. We want to minimize fusion levels. And I think that the durable result is really the critical piece. And when we start focusing on stupid, trivial outcomes like EBL of, an MIS TLIF versus an open TLIF, where the difference is, the p-value is extremely small, but the difference is 150 cc's, or even the difference is 800 cc's, like that doesn't matter. That's not going to change anything. What's really going to change things is whether or not that fusion lasts, right? Or does it go on to mechanical failure? And have you done everything you can to reduce any negative effects of sagittal plane malalignment on health-related quality of life? So something that thought about this, and this is like, I'm friends, I love all the people that wrote these papers. They're my friends and mentors, but I totally, completely disagree with them regarding the concept of age-adjusted alignment targets. And age-adjusted alignment targets were developed from the idea that as we age, right, I already said that age is a kyphosing, life is a kyphosing process. As age goes up, people become more forward. That's what happens. The discs, I tell all the patients here, even the kids, God did not do a great job when he made the bioengineering of a disc. The discs aren't meant to last as long as us yet. And the discs degenerate and you become forward. So they came up with alignment schemes based upon expected sort of population-based expected health-related quality of life converted to ODIs, and then said, well, if ODI less than 20, this is where a 75-year-old can stand, and this is where a 35-year-old can stand. And ODI less than 40 will be here and here. Now, I was a math major in my undergrad, and that's my old life. And the problem, so one of the problems is that the theorem now is age-adjusted alignment targets exist. And everything that comes from that is a corollary. So one of the corollaries that came was, well, if we follow age-adjusted alignment targets, we may actually decrease proximal junctional kyphosis. So they did a paper using the targets from the theorem to prove the corollary. Problem is, in my mind, the theorem is totally incorrect. Does it pass even face validity? Nope, not at all. Age is not static. And I go back to the category slide. What if your patient is 74 going on 75? Do you fix them like the 74-year-old category, or do you fix them like the 75-year-old category? Or suppose you fix them in their 40s and then they live 20 years. Are you going to go in and do a reverse osteotomy and push them forward? Of course not. Really, like the mathematical proof against age-adjusted alignment comes from the fact that sagittal malalignment in age is primarily driven by degeneration. Degeneration of the disc, loss of anterior column height. Loss of anterior column height leads to loss of lordosis and or frank kyphosis in the lumbar spine, and leads to increasing kyphosis in the thoracic spine. Aging and senescence also lead to atrophy of the paraspinal extensors, right? Everyone likes to talk about sarcopenia, this and that. So sarcopenia will lead to an inability to maintain the normal alignment. And now, if age and degeneration go hand in hand, and sagittal plane alignment goes hand in hand with age and degeneration, the degeneration is the confounder. And in their work, they did not control for the strongest confounder possibly in all of spine surgery. And you can't do that, right? You just can't do that. That's goes against mathematics. It's not just passion now it's facts. Furthermore, this whole idea of age versus chronological age, right? The number of trips around the sun, which is kind of random, versus biological age. And biological age is epigenetic modifications that have happened over your life, happened to your parents, right? There's transmission of epigenetic changes. And we understand now through Chris Ames's work, I think a whole lot better, that age is just a number, and we are going to see healthy 78-year-olds, and we're going to still see pretty sick looking 48-year-olds. And using chronological age for anything, I think, is going to send us in the wrong direction. And is there any other evidence for this? So this is the best that exists now. I'm working with Steve Lewis and his team in Toronto on biomechanical models of flat backs, but age-adjusted alignment targets in general argue against perfect correction for older patients. And what does that lead to? That leads to persistent compensatory mechanisms or increased pelvic tilt. And this was published in the Journal of Spinal Deformity, where it goes left to right is flat to normal. You get increasing shear stresses at the adjacent segment, and that's what leads to proximal junctional kyphosis. Compressive forces at the adjacent segment are actually not different irrespective of your alignment. It's the shear, and it's the shear because the pelvic retroversion is taking the implants one way and the patient's falling forward and going the other way, and that creates shear, and that leads to failure. And I believe that actually it's not just, I don't think massive failure like PJFs. I think adjacent segment degeneration and PJF are categories of one and the same. And it's a not harmonious biological system created by malalignment. Oh, wrong way. And what if the patient has a total hip arthroplasty? I think this is something also that you need to think about. Like, this is the paper from JBJS. This patient has a flat back and does not get a 3-column osteotomy. And look at how far in front the pelvis is after, or the hips are on that postoperative film. And that neck is approaching horizontal, and that's going to fail. And that is not good surgery. And one of the problems with the total hip world is that the acetabular version changes, observed acetabular version or effective acetabular version changes with pelvic retroversion. And we need to figure out how we're going to fix these people so that one, the joints don't dislocate, and two, in native hips, if you fix someone to the pelvis, T10 to the sacrum with iliac instrumentation, and fix them flat so that they have to retrovert, they then have relative undercoverage, and it's essentially an iatrogenic acetabular dysplasia. And Keith Bridwell, my old partner, had papers that said, okay, like you get fixed to the sacrum and a total hip's coming next, and maybe it doesn't need to be. Maybe that doesn't need to be the story. Maybe if we fix the pelvis correctly and reduce pelvic tilt to what is normal for the patient, then the cartilage will continue to load normally, and we will have lower rates rather than higher rates of total hip arthroplasty, or rates equivalent, rates as expected for patients, rather than encouraging failure. So age-adjusted alignment parameters come around based upon health-related quality of life, and I am a huge fan of the global alignment and proportion work by Charlar and the European Spine Study Group. And they, through conversations with Dr. Rusoli at their meetings, really recognized the need for spinal fusion that leaves you within the cone of economy. And in their paper, actually, they found that older patients were actually less tolerant of malalignment. So now you have a complete sort of battle between age-adjusted and gap, right? The two concepts are going totally opposite one another. One says fix them a little bit forward. The other one says do not. They're less tolerant of being fixed forward. And the external validity of this has been challenged, and that's not surprising, really, meaning people have applied gap to their own patient populations, and it doesn't always work. And that's not, again, not pseudarthrosis can happen for a number of reasons. PJK can happen for a number of reasons. If you choose the wrong UIV, your PJK risk is probably going to go higher. If you do a big lobster tail laminectomy and then use only cadaver bone for your bone graft, you're going to have a higher risk of pseudarthrosis, irrespective of your alignment. But I think the concepts that the European Spine Study Group have proposed are really key. One primary concept is that sagittal plane alignment outcomes should be assessed by mechanical complications and not by health-related quality of life. And I don't have any slides about this. I've done some work on it. It's very hard to predict health-related quality of life with any accuracy. The variation in people's perception of their disease is so wide and affected by their own experiences, expectations, perception of pain, that using HRQOL as the primary outcome measure is probably not the right thing to do. And having discrete measures like proximal junctional failure and pseudarthrosis, I think, are excellent. And the European Spine Study Group and GAP, in addition to sort of noting that leaving the cone of economy puts you at risk for mechanical complications, also describe the ideas of not only lordosis magnitude, but relative lordosis distribution. So where is it distributed? Where is your pelvis? Do you have a normal pelvic tilt or abnormal pelvic tilt? And what about your global standing alignment? And all of these things go together to create this nomogram that are used post-operatively. If you read the paper, they have the equations so that you can come up with individualized targets for each of their little things, though I will caution you that things like relative pelvic version, you can't calculate that. And you can't calculate that intraoperatively because pelvic tilt is a postural measure. And so as an example of the sort of collision of age-adjusted and gap, and how do we come up with targets? So this is a patient from the multi-ethnic alignment normative study, which we called MEANS. This is an asymptomatic 71-year-old, right? I don't have their ODI score here, but the ODI score was less than 20. So essentially asymptomatic, normal, according to the population. And they have a very high gap score. So now in the age-adjusted world, we would say, no, low ODI, just fix them like they are, they'll do fine. And gap would tell you, no, 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 you fix them like this, you're going to have a problem. And if you look at these x-rays, this is actually a pretty tricky case. That is high pelvic tilt for that patient. That is, and a little bit of proximal thoracic kyphosis that you need to be careful with. You can get really up the creek really fast in this case if you don't bear in mind what is going on. So this is where this brought me, was to the multi-ethnic alignment normative study. And with one of my colleagues, Jeff Hills, who trained with us in WashU and is now at UT San Antonio, I said to him, I want to study, first of all, you know, the GAP used some of our patients from this, and people in Rusoli looked at asymptomatic. And I said, no. Asymptomatic and deformed are in there. And we don't want asymptomatic and deformed. I want to know exactly how people stand normally. So we went, it's asymptomatic volunteers, almost 500 from France, Japan, Tunisia, Singapore, and the United States got EOS films, skull to ankle. Then we went through and we eliminated anyone with disc degeneration, end plate sclerosis, anyone with a coronal plane deformity, and any one person for some reason snuck through with an ODI over 20. And I said, I want to know how normal people stand. Let's figure it out. Let's see if we can make, because the R squareds, right, which is a measure, one measure of model fit for lumbar lordosis according to pelvic incidence, are very small. It's 0.3, which means that there's substantial variation around that mean. And that means that when you use that equation to pick it for your patient, you may be off by quite a bit and not accurate. So we measured a whole lot of different things, and we included the vertebral pelvic angles and the vertebral body tilts. The vertebral pelvic angles are the angles subtended here from the center of the sacrum to the center of the femoral heads to the center of the vertebral body. And we did it for every single VPA and every single vertebral body tilt. And if you look here, these two cases here are very interesting. This is a PI of 80, right? It's a Rusoli type 4 patient. PI of 31, this is gonna be a Rusoli type 1. You can see the subtle C and a little whoop, and the L5 is the apex. L1 pelvic angles, very different. A difference of almost 20 degrees here, right? 16-degree difference. But the L1 tilt, right? That's a measure of the relationship of where L1 is in space to a vertical through the hips, identical. The T1 pelvic angles, 14 degrees different. The T1 tilts within 2 degrees of one another. Pelvic tilts, wildly different. Pelvic tilt of this Rusoli one is almost 0. It's 2 degrees. This one is almost 20 degrees, right? And we just said 20 degrees might be moderate deformity. That's not good. It's totally normal for this patient. First, right, I already railed on sagittal alignment by age, but what do we look at? So in our study, we have now excluded degeneration. And I don't think there's any other way to control in a stats study for degeneration by excluding it. There's no way to put in a variable that accounts for degeneration, because degeneration in and of itself is a kind of nonsensical category. So you look at it like this, right? This is age is the x-axis, and those are flat lines. And that says that in the absence of deformity or degeneration, sagittal plane alignment is not associated with age. Age is not the driver of sagittal plane deformity. Degeneration is the driver of sagittal plane deformity. And what else do we look at? So this is what I just said. The tilt measures, the measure of where this thing is in space versus that vertical line going through your hips and knees, is independent of your pelvic incidence and the pelvic angles. The pelvic angles and the pelvic incidence are highly related, and the pelvic angles and your pelvic tilt are highly related, because pelvic tilt plus your vertebral body tilt is equal to your vertebral body pelvic angle. And so how can we use this difference and similarities is that if we look at the L1 pelvic angle by pelvic incidence alone, the R squared of that regression is 0.6. That's really high for a biological model, right? And the L1 pelvic angle, again, is this. It's from the center of the sacrum to the femoral heads to the center of L1. And if you think about it, it is a measure of both lordosis magnitude and distribution. And the nice thing is, so here's our regression line, and the R squared is 0.6, which means we're going to have dots on either side of it, right? These are the variants about the mean of the regression, and we're trying to minimize our residuals. The nice thing is that these 80% confidence intervals, prediction intervals, are 4 degrees, right? It's 4 degrees on either side. So if you have now an 8-degree range for your L1 pelvic angle, where you are probably going to be okay in terms of prescribing individual alignment targets. Now, if we go back and look, and we look at just lordosis measures, right? We ignore distribution. There are interesting things to see here. So the first graph, the darker lines up top are higher PI, the ones lighter blue at the bottom are lower PI. And people, and you look here, L5S1, everyone's kind of the same to some extent. Not really, that's actually, I take that back, erase that, Raj.
Sure.
It's independent of pelvic incidence. You cannot predict your L5S1 lordosis from your pelvic incidence. On average, people have 25 degrees of L5 to S1 lordosis. And that is clearly affected by the shape of the L5 vertebral body, but also evidence for everyone that industry has sold us flat cages. Now they call them hyperlordotic. I tell them all the time, hyperlordotic's the dumbest name you could have. They're actually appropriately lordotic. It's about time. But if you look here, right, that all of the pelvic incidence values, they start the same, and then you go to L4S1, they're still not wildly different. There's no relationship between PI and the distribution of lordosis there. And it's not really till you get to L3 where you start to have a positive slope in this regression where pelvic incidence begins to affect your ability or begins to affect the distribution of lordosis. But the R squareds are all still very low because it's not describing the shape. And how do you conceptualize this? So here's one, pelvic incidence of 40 degrees. And so a normal lordosis magnitude for someone with a PI of 40 is 54, 60% of PI plus 30. So now let's think about our PI minus LL absolute value of 10 and say, okay, we hit them with 35. We're within 5, we're money. We're going to go great. Everyone's giving each other high fives. 2 ways you can do 35. One is you do it high. So imagine perhaps a patient with a PI of 40 who's had a prior 4-to-1, and then you go and do a hyperlordotic anterior column reconstruction with those big cages in a lateral position, and you put all of that lordosis up top. You end up with a high lumbar 1 pelvic angle, and the only way for that person to stand upright is to increase their pelvic tilt a ton and to extend and flatten their thoracic spine. And they'll extend and flatten their thoracic spine to either totally flat, sometimes lordotic, certainly less than 20, which is in general not normal for anyone. Now what if you say, oh no, Kelly, I'm not going to do ACR. I'm going to go in, I'm going to do an L5 PSO, or I'm going to put it low if they have an A-lift that I can get into, but you only hit 35. Well, now your distribution is nice, and your relative lumbar lordosis distribution from the gap score will be great, but you actually still are not going to do well because it's still too low, right? The L1 pelvic angle is still too low, and they need to extend through the hips and pelvic retroversion, and they need to decrease their thoracic kyphosis even more, right? More extension. Now, suppose you say, oh, no, I'm not going to fall for that. I'm not going to give them 35. I know that that the PI, if the PI is 40, that the lordosis needs to be around 50 or more. But you still put it up high. You've still made a huge problem. They still need to retrovert and flatten their thoracic spine. Only if you nail the lumbopelvic angle will they stand upright and balanced. So hopefully that makes sense and puts it into easier to use terms. And this is how I described it to Larry Lenke. And he said, Kelly, this is great, but like you're being ridiculous. We want categories and equations. Make it simple for us. I know what you're saying, but this is unusable with this flight of ideas. So how can you think about it? Target lordosis when you're planning surgeries will be about 60% of your pelvic incidence plus 30. Your target L1 pelvic angle is going to be about 50% of pelvic incidence minus 20. And when you have even those two concepts, you can sit down and use SurgiMap or whatever company modeling software, but I don't think you should be, particularly deformity surgeries, you shouldn't be doing them without planning and without modeling. And I've done visiting professor things at esteemed institutions that talk all about value and this and that, and then when we get to talking about angles, they say, oh, it's not about angles. When you take them to the operating room, it's literally only about angles. That's all you can affect in the OR. You can't affect whether their husband or wife left them, or the dog died, or they had to walk too far for parking, all those things that affect HRQOL. You need to have a plan, and I think that you should try to fix them perfectly. So that's an idea for lumbar lordosis magnitude and distribution to get the L1PA right. What about the thoracic spine? What's very interesting is that the T4 pelvic angle is oftentimes within 4 degrees of the L1 pelvic angle, right? So if you look here at the distributions here, L1 is here and you go straight up and T4 is in the same place. And that gives you some idea of where to fix the thoracic spine. How much kyphosis do they need? Or how much do you need to take out? And because ultimately, a C2 tilt of close to 0 is the goal. People stand within a pretty tight range of about -2 to 2 for their C2 tilt. And that is essentially stating the Hewick's odontoid hip axis. All right, and this is all theoretical, right? I'm like a theoretical physicist at this point, just talking and showing you guys cartoons. Does this work? So then we went to the International Spine Study Group's older patient series and looked and did what I thought was very high-end statistics, because it's not just a logistic regression. We looked at how does L1PA deviation and T4L1 deviation affect the probability of any individual for mechanical complication. And for this study, we chose only people fixed T5 or higher to the sacrum. And we sent it into JBJS and they didn't love it, in part because I think that they thought we were just talking about T3 to the pelvis. We're not. What I did was I chose T5 to the sacrums because I want to control what I can control. And I want to examine only alignment. And if we include T10 to the sacrum patients, I don't know how to control and understand the motion and responses of the unfused segments. So by fixing our T4s and L1 pelvic angles, we can actually investigate what the effect is of those. And so what we found was that as your L1PA deviates from normal, both undercorrected and overcorrected, and mind you, this is controlled for age, your risk of failure goes up. And now, this is, the green line is we nailed the T4-L1 relationship, and this line going right to left to right, is we didn't nail the lumbar spine. And so you can see as you have overcorrection and undercorrection, your risk of failure goes up. And now the yellow, light blue, orange, and dark blue, those lines are, well, we didn't nail the T4-L1 relationship. And you can see that even if you hit L1 perfectly, your risk of failure is 30 or 40% if you have a gross mismatch of T4-L1, right? Plus 15 means T4 is way in front of L1 post-op, that's a flat back, or residual hyperkyphosis. And then as you deviate in the lumbar spine alignment, then your risk of failure goes above 50% for some of these people. And then we said, okay, well, fine. What about health-related quality of life? And there are a number of people that say, like, oh, health-related quality of life doesn't matter. It doesn't matter in terms of sagittal plane alignment because the R-squared is low. I think that that's a misinterpretation of what the R-squared means. So we did partial effects plots, which are the ways to examine the effect of your dependent variable of interest on an independent variable. So what we were interested in is the ODI and the SRS. I'm really just interested in the SRS subdomains. The subscore is a composite measure of self-image, pain, activity, and mental health, and actually tells me nothing. But what you can see here is that as you go forward, your C2 pelvic angle, as it goes higher, your ODI gets worse. As your C2 pelvic angle gets higher, your activity scores go down, your pain gets worse, your self-image gets worse. So I think what this shows is that there is a negative effect of malalignment on HRQOL in the setting of a negative alignment affecting your risk of mechanical failure. And you can see here, there's multiple ways to malalign people, right? So the lowest risk is we hit L1 and T4 relationship, right? There's PJK junctional failures, less than 5 patients here. Now, what about your flat and T4 is positive? That's the worst. An equal number of successes and failures. 50-50. That's terrible. Not good. Case examples for you. So here is a patient with thoracic hyperkyphosis, lumbar hyperlordosis that gets fixed with a good L1 pelvic angle, a good T4-L1 relationship, and now C2 is over It's a little negative. The C2 tilt's a little negative, but not bad. Here is a patient that gets fixed with a very small difference between T4 and L1, but a too high L1 pelvic angle, and the head falls over when at 6 months they've PJK'd. We've brought this to our colleagues in Europe, and some of them say, no, this is you guys Americans with your angles. And what, excuse me, I argue is that we are providing an objective measure of the Rousseli classification. Rousseli is hard to use for inter-rater reliabilities, right? It's what someone calls a 2, someone else might call a 3 or a 1, and it becomes difficult. And what we show here, right, is that according to the Rousseli classifications, the L1 PAs tend to work. The distribution of the L1 PAs, according to Rousseli 2, 3s, and 4s, pretty tight variation around that line. Rousseli 1s are really rare, which is why if you read a paper, they say, oh, 40% of our population was Rousseli 1s. You got to really think about what they're doing, unless it's a paper about treating people with PI of 40, which no one writes anyway. One of the interesting things is that if you look here too, what you see is that the T4-L1 relationship, while kind of close to 0, as your PI goes up, your T4 tends to come backwards a little bit more. And it's a little bit more forward in low pelvic incidence patients. And so how do you use this stuff? And this is not my case. This is a case someone sent to me and said, hey, Kelly, what should you do? This is what my partner said to do. Here's our proposed plan. It's a patient with a prior L2 to L5 with an open L5S1 disc. They have essentially no lordosis from L2 to L5 with a pelvic incidence of 45. And I mean, I see this right away and I think, okay, I know exactly what I want to do. And I also know that most people are going to think I'm a complete lunatic. So we'll see. I'll show you what I proposed and explain why. So the first proposal that he said was, well, why don't we just put a big ALIF in? And I said, I don't think that's going to be enough. You put a 25-degree ALIF in and your L1 pelvic angle goes down to 9. In theory, you want your L1 pelvic angle to be 2, right? 2 degrees, 3 degrees. So that's 6 degrees high, kind of high. Now, what if we put in a 30-degree? The modeled L1 pelvic angle goes down to 6. So we're getting there, but we're still not there, and that is a pretty extreme ALIF. Other people say, well, do an ALIF and then do some type of expandable or hyperlordotic procedure at L1, L2. Well, people don't have hyperlordosis at L1, L2. Maybe the highest of pelvic incidence patients do. They have some lordosis, but a PI of 45 does not have lordosis at L1, L2. So you do 25 degrees at L5S1 and 10 degrees at L1, L2, and your LPA goes back up. Look at you went from 6 with a 30-degree. Now you're going to do a smaller ALIF and more lordosis up top, and your L1 PA goes up, not down. And I said, no, I hate to tell you, but I think you got to do an ALIF and a PSO. And so that's what we modeled. You do 25-degree ALIF and you do a small PSO. I don't know if there are people from France listening, but I always credit the French with this, that I never understood the SRS when Rousseli or any of them would get up and say like, oh, I'm going to do a small PSO at L5, small PSO at L4. In America, a small PSO, that sounded crazy. We always assumed PSOs were these big, huge surgeries. But if it's fused front and back and you need 15 degrees, you need 15 degrees. And the only way to do that is a small PSO. So that's a 20-degree PSO. That's a pretty small little bite. And you can see here, right, that is the one that puts the patient in normal standing alignment. And that's what was done. I got to update this slide with the post-ops because it looks sweet. This is also the L1 pelvic angle can be used for intraoperative alignment tools. And I think the absence of using end plates actually makes it much easier, right? When you start having end plates and scoliosis with obliquity and you're trying to find the ellipse and the midpoint of the ellipse, it gets harder. That's what my partner Peter Newton always says. I don't think you can measure any of this stuff on a standing radiograph. And I don't think he's wrong. I think using the centroids is far more accurate and will have much higher inter-rater reliability. So here is a patient, this is a complicated patient, right? Pelvic incidence of 60 with a loss of lumbar lordosis, with a fusion from L3 to S1, bad degeneration above, as well as distal junctional kyphosis below a prior C2 to T2. And you say, well, what should we do? Interesting to note also that this is why we shouldn't be using SVA anymore. SVA is a useful number for tracking any individual over time. So if you want to measure SVA once, you got to measure on that patient again, but you cannot compare SVAs. SVAs don't mean anything in a population. This patient's SVA is 0, and she's in terrible shape because the SVA is not a measure of standing sagittal plane balance. And so what we did to that person, this patient was a very large L4 PSO, and you can see he measured the L1 pelvic angle intra-op as we bent the table to get the L1 PA where we wanted it, fixed her all the way up, because going halfway would just still have a DJK above, and she's standing in normal sagittal plane alignment, and she was off of opioids by 3 months, having come in on several years of OxyContin. Other takeaways from this concept, and this is, I think, really important, and I didn't understand it for a long time, is avoid the Roussely false type 2. The false type 2 is someone with a subtle S and high pelvic tilt who will delude you into thinking, oh, they're good, right? SVA is low, they have horizontal gaze, but they have high pelvic tilt. It's the wrong magnitude and wrong shape of lordosis and thoracic kyphosis. And I think that they tend to do worse, and perhaps mechanical complications won't be worse, but when you look critically, if you collect HRQOL, you will find that their HRQOL are higher, and you are robbing those people of the opportunity to be better, which is the whole point of undergoing these dangerous surgeries and expensive surgeries. So in summary, the magnitudes and the shapes of sagittal curvatures matter. The vertebral pelvic angles describe the magnitude and shapes, and it's based upon pelvic incidence, which you can prescribe then at an individual level. And unlike people who say sagittal plane doesn't matter that much, you guys talk about angles too much, I think that if we can nail perfect surgery for these people, we will do the best we can for delivering value in healthcare, right? We're going to do these surgeries. We need to reduce mechanical complications, reduce reoperations, and we need to do the best we can to maximize PROMs. And thank you. Let me know. You guys, and my email addresses are there. Feel free to send me an email if you have questions or concerns.
Thank you very much, Dr. Kelly. It was really amazing and insightful talk. So few questions, if you like to take, we'll just take 2 questions, considering we must be exhausted after this long talk. So as we know, the proximal junctional kyphosis or even distal junctional kyphosis is considered mostly because of the gravity, and we can't fight against the gravity. The more, if we fix a T10, even if we correct with all the angles, it might have a chance of causing proximal junctional kyphosis at the above level. When we go higher at T4, it will give PJK at the higher levels. So what are your thoughts on doing levels of instrumentation with the angle corrections, and how it will lead to the clinical implications, better patient outcomes with this new angles correction deformity you discussed?
Well, I think fighting gravity, if you are standing in the cone of economy, you're not fighting gravity anymore. And for me, that was like really one of the things that was revealing about this, was that I started doing PSOs a little differently and getting 40, 45 degree PSOs when I needed them, which in my prior training and history was like way too much. That was great. You're overcorrecting. And the patients would come in happy as clams because they could stand at the window and watch traffic go by for the first time in years. And you know what they hated? Sitting down. If you nail a lumbar lordosis, they hate sitting down, but it means when they stand up, there is no work. And if you are getting PJK because of gravitational pulls, it means either your thoracic spine is too forward or your lumbar spine is flat. But if you nail it, gravity goes through it, and they don't have these ventral displacement forces, the shear in the adjacent segment.
Understood. Thank you very much. Just one more question. Most of the planning we do regarding all the surgical alignments are before the surgery, and we do intraoperatively do have certain planning that intraoperatively these angles we correlated for the 6 weeks postoperative standing x-rays. Anything you think about the intraoperative angulations we could measure and which will correlate it for the standings?
Well, that's why I like the pelvic angles. I mean, especially in adult spinal deformity, where by and large you're fixing them to S1, you can measure the L1 pelvic angle. And if you can measure it, it should not be wrong. do whatever you got to do to get it right. Unfortunately, there are a number of places that still don't have 36-inch cassettes portable in the OR. So in my, everything I've done, everywhere I've worked, I could get those and measure the T4 and L1. Excuse me. Now with navigation technologies and the intraoperative CT scans and these three-dimensional reconstruction fluoro things that are starting to stitch them together, we're also going to get to a point where, realistically, you shouldn't be doing these surgeries if you don't have access to the technologies to give and that's not like crazy technology. I'm not saying, things that should be out of reach for people in this day and age if you're doing such expensive and risky surgeries for a patient and a healthcare system, that you'll be able to measure all of these things and not get it wrong. You shouldn't get it wrong. My goal now, my real interest is in democratizing the idea of spine surgery and ensuring that patients around the world get the same care, because we can do that with technology. The idea of like the surgeon, sort of surgeon expert, can kind of go away for 90% of what we treat, I think.
Thank you very much, Dr. Kelly. Your talk will be definitely helpful and beneficial to all the spine surgeons across the globe, as well as the fellows and the residents, the young spine surgeons. Thank you very much.
Thank you.
Over to you, Poonam ma'am.
Yeah, I think it was a really excellent talk. And thanks, Dr. Kelly, for sparing your time. I think in summary, I think it looks like you're trying to give a definition for malalignment in sagittal spine. And trying to extrapolate it to practical surgical executions. So I think that's a great step in understanding the sagittal spine balance and the spine balance overall. Thanks very much. So it was an insightful talk, very, very insightful talk.
Thank you.
Thank you, everyone. And thank you all the viewers across the globe.
Thanks.